Okay, I'm going to get started. It's 12 o'clock on the dot, and I know we have a lot of great content to cover today. Thank you again for joining the DISYS Corporation's monthly webinar series. We are trying to focus our webinar series every other month in the healthcare vertical. My name is Shelby Weir. I am the National Director for our healthcare practice, and I work with our DISYS clients that are providers and payers nationally across the country. I'm very excited to have a special guest with us today, Peyman Zand. He is the Director of Strategy and Governance for Rex Healthcare. I'll talk a little bit about Peyman in a moment. I did want to mention in the beginning that if you do have a question for Peyman, please feel free to use your chat. At the end of this seminar, we will take questions and we'll give answers to the audience. So I wanted to encourage everyone to reach out through chat and let us know if you have questions for Peyman. I'll talk a little bit about Peyman. I've got a chance to get to know him over the last few months. Peyman is, as I mentioned earlier, the Director for Governance at Rex Healthcare. He has led their ICD-10 initiatives, and he's also participating as a DISYS fellow, a consultant to our clients here. So we really appreciate having him. Some things about his background. I will give you a little kind of off the, not healthcare related, but in his previous life, Peyman was the project manager for leading a development of a professional baseball team, and he did everything from purchasing a team to getting the stadium built for the retired CEO of Dow Chemical. So he's done quite a bit of things in his career. And Peyman, I'll let you you join in and say hello and give us a little bit more history on your background.
I appreciate it, and I appreciate the welcome, Shelby. It's good to be here with you, and yeah, I guess it's a testament that some of us IT folks actually get to have a life outside of our normal, regular business as well.
Absolutely.
Well, without further ado, let me go ahead and get started on this because we have quite a number of slides that we're going to be covering. And as Shelby mentioned, we'll try to leave as much time as we can to take some of the questions at the end, and we'll be glad to try to get as many of those in as we can. And then I'll give you my contact information at the end as well, and feel free to contact me even after the session and with any questions you might have. Just to cover the bases, I know all of you know what ICD-10 is about, but just wanted to make sure that we level set that it is a new international classification of diseases which replaces the ICD-9 code. And this ICD-9 code has been used in over 30 years, and it really is time for us to move over to this new ICD-10 code. I'll put out a picture here of where the other industrial nations are in just a minute, but it's sufficient to say that many of the industrialized nations have already moved to ICD-10. This level of sophistication and complexity of the ICD-10 is much greater than ICD-9. We put a couple of bar graphs here on this slide, which shows your diagnostic codes going from 14,000 to almost 70,000, and procedure codes going from about almost 4,000 to 72,000. And this demonstrates the level of sophistication that we would be going into. So as you can imagine, 30 years ago, we didn't have smartphones, we didn't have PDAs, we didn't have a lot of the technologies that are available today. And frankly, some of these technologies may be really useful as we go into this ICD-10 era. So let me put out a couple of slides here just to give you an idea about where the nation is. So American Hospital Association, about a couple of years ago, went out there and asked some questions about, are you ready for ICD-10? And as you can see, over 70% of the folks that were asked had either not started or were just getting started on this one. And it was interesting as we were preparing for this webinar today. We thought we should do our own assessment and see where folks are. So another assessment was done by DISYS recently just to see where folks are today. And as you can see, this is the most recent one. And we still have somewhat of the same situation here, where the majority of the organizations have either not started or are just getting started on it. We'll talk more about this, and we'll talk more about the impacts of the ICD-10 and how long this program will take. Another question that American Hospital Association asked was, do you have an organization or a team that has been created? And again, overwhelmingly, the response was no. And in a DISYS poll, we had also asked the question, what are some of the biggest concerns about ICD-10 implementation? And although I think these were spot on, for example, resource availability and training was the top two on people's mind, but I was personally surprised to see the impact of the cost being a little bit further down. And I think hopefully by the time we get done with our webinar today, we'll demonstrate the impact specifically around the cost of the ICD-10. All right. A couple of testimonials that I thought were, again, very spot on. Dr. Steindl called it expensive and traumatic, and I think that's exactly right. It will be expensive. And then Deloitte also called it neither easy nor quick. And that's one of the other reasons I want to talk to you today about the fact that if you haven't started your endeavor in ICD-10 remediation, you should start it as soon as possible. Just to get us started, again, a little bit of a fun fact. Did you know that there will be a code for patient injuries that occur in chicken coop? Well, it's a fun fact, but at the same time, it underlines a very key component issue with the ICD-10 codes. We were thinking about ICD-10 codes being something that it is going to impact the medical records staff members, maybe the doctors, maybe the clinicians. But as you can see, as patients walk into the registration, the fact that they were injured in a chicken coop or they were injured on a sidewalk, that would all matter, and we would have to be coded appropriately. So that level of specificity did not exist with ICD-10, ICD-9 code. Sorry. They also mentioned, let's talk a little bit about where the rest of the nation. So even though ICD-10 codes were developed about 30 years, 25 years, 30 years ago, the first implementation of the ICD-10 codes was in the United Kingdom about 17 years ago. And the most recent ones were Canada followed by China, who are all on ICD-10 codes today. But it's really interesting to note that U.S., even though it's one of the last ones to go live with ICD-10, will be implementing this ICD-10 code for reimbursement as well. So I'll just repeat that one. This is the first country, United States will be the first country that will use ICD-10 codes for reimbursement. This is why the comment was made about the fact that it may be very expensive endeavor, even more so than other countries. And interestingly enough, World Health Organization actually plans to retrofit and go back to the rest of the countries and implement the reimbursement in other countries after the United States has completed as well. On the heels of ICD-10, by the way, they are already working on ICD-11. So I don't think this is going to be a done deal here, although ICD-11 to 10 is not as traumatic as the ICD-9 to ICD-10. Let's take a few minutes and talk a little bit about the impacted work areas. As I mentioned early on your lower right-hand corner, you know the coding staff members will be impacted. Obviously, we know the ICD-9 codes and to ICD-10 codes will be much more challenging to code, will take a lot more, and we'll talk a little bit more about the impact to the coding staff members. But from a waiting room, the front and at the front desk, as the patients come in, and our front desk staff members having interact with them. Today, you go to a doctor's office, they might give you a piece of paper to fill out. And this may be much more sophisticated in the future, where you might have to hand out a PDA for them to use, because there's a lot more information that we might be needing. To the manager's office, where the policies and procedures might be changed. The vendor relationships might be changed. The payer information obviously will be changed. Budget consideration and training consideration for ICD-10 will impact the backfill for nurses and doctors and other practitioners that you have. In your clinical areas, patients would have to be notified of the specific health plan changes and coverages that they would have, because these will all change with the level of specificity that we're talking about. The physicians would have to be completely trained in the ICD-10, because as we'll talk more about some of these detailed codes, you'll see that where previously a broken arm in ICD-9 was a sufficient diagnostic, under ICD-10, you'd have to very specifically talk about whether it was a left arm, right arm, whether it was the femur, whether it was hairline fracture or broken. So all of that detail would have to be specified by the physician. The lab, obviously documentation changes in the lab and reporting changes. And something as simple as reporting changes, by the way, might require reports to be completely redone, because they might not fit in the same paper anymore, or they might have to be represented differently to the patients or to the lab and practitioners. Pharmacy, and of course, last but not least, the billing. This is going to be a major area that would get impacted by the codes that are submitted to the payers. And if those codes aren't accurate, and we anticipate it up front, some of them will not be accurate, will have some impact there as well. So just about every work area within your healthcare organization will be impacted. But let's talk a little bit about the work processes as well. To the right of your screen, you'll see the health information management or your medical records department. Obviously, we talked about the billing and the payers. So those we know will be impacted. And when we talk about work processes, we're talking about workflows. So as the patient comes into the hospital, gets treated, a bill is generated, a bill is sent out to the insurance company, that constitutes all of the different workflows that we talked about, that we're talking about here. And again, each one of these areas, from scheduling, admission, patient care, case management, lab radiology, transcription, performance management, all of those will be impacted. I should mention that at Rex, we started our work process or workflow documentation, and this documentation was probably started about 8 months ago or so, and we're maybe about 80% complete with documenting the existing workflows. We're just getting ready to actually start designing our new workflows based on the ICD-10. So this takes actually quite a bit of time to not only understand how your current workflows work, but also to design your new ICD-10 workflows based on the existing work processes and work areas that that's going to be impacted by ICD-10. To demonstrate why this issue is really a financial issue and why the CFOs should pay close attention to this one, we use this following example that, and again, I'm not a doctor, and so apologize if I butcher some of these words here and the diagnostic and procedures. So under ICD-9 code, which is the one on the top there, you'll see a diagnosis, which is about an aortic aneurysm and hypertension. And a procedure that was done was the graft implementation in the thoracic aorta. This procedure and the care for the patient would result in a $30,000 and over $30,000 cost and reimbursement to the hospital by the insurance company. As you translate this one into ICD-10 code, a small difference between the procedure codes could make a difference in how much you get reimbursement. So the one on the top under ICD-10 is the correct one. So hypertension NOS turns into essential hypertension. The aortic aneurysm changes actually to aortic aneurysm without rupture, but that is not what causes the difference in the cost. It's the procedure code. So whether you have a revision of the thoracic aorta or replacement of the thoracic aorta makes about a $13,000 difference in your reimbursement amount. This fact that you could have that much difference in just one or two code differences is the piece that should get everybody's attention, and why we're talking about the fact that this could be a very expensive endeavor, especially up front, and as we work through some of these potential errors that could happen. Let's talk a little bit more about some of the additional impact analysis that we've seen. And I got to preface this one. The numbers we see here are the numbers that we saw from other countries that we put out there, from Canada to Europe to China, etc. And if you recall, I mentioned the fact that those other countries did not use the ICD-10 code for reimbursement. So it is going to be this is going to be an interesting change for the United States to see what the impact of reimbursement will have on these numbers. And to that point, we believe that these are actually very conservative estimates. So the first bullet is a 40% increase in the coding resources. So if you have 10 individuals doing medical record coding in your hospital, our anticipated increase would be up to about 14 individuals. Now, would that be sustained throughout? We think it's a very good possibility, but we know, for example, in Canada, where they did take a hit of 40% in the coding resources, none of the hospitals ever recuperated anything more than 20% hit. So in other words, if you had 10, you went up to 14, you could not get below 12 coders going forward. So additional staff members may be needed. Estimated 10% of the charts will require more documentation. Again, because of the level of specificity, we need to have a lot more documentation that is added. That additional documentation by itself would create more work for the coders, and that's why those coders, you need additional coders to come in and join the staff. 25% increase in RAC audit take-back. You know, obviously, for those of you who've been in the in these audits, you know that that's a major issue. And again, those could be conservative depending on what Medicaid, Medicare would think about and how it would handle the situation. Payer errors by itself might raise 6 to 10%. So then, when you add the insurance company error rate and you add the additional documentation that we would require within the hospitals, obviously a 10 to 25% increase in the initial denials is not an unusual situation. This is precisely the reason why Rex Healthcare, for example, anticipated that we might have an impact in our accounts receivable days. And so we have actually asked twice to increase our level of credit so we can actually sustain the delays in our accounts receivable potential due to the ICD-10 impact. So when we talk about this will be traumatic and expensive, these are the reasons why we believe that the expense would be a major issue for the hospitals. Later on, when I talk about some of the governance structures that we put in place, you'll see why our CFO has taken the lead of being the project sponsor for this one, because it does have a financial impact. Some of the accounts receivable days at risk information is on the charts below. Drop in coder productivity, drop in physician productivity. and the rework that's required against some of the key contributors to this. Well, just like my old childhood hero says, there is something good about all of this stuff. So the ICD-10 does have quite a bit of benefits that I haven't listed all of them. I just listed some of them here for your knowledge. But we can have much better disease management. We will have much better understanding of the healthcare conditions and the outcomes. We can do better disease monitoring and reporting worldwide. Recent incidents like the SARS incident that happened a few years ago, underscores this one, that to be able to not only report this level of detail for these sophisticated illnesses that are coming, and the fact that these illnesses can actually transfer from one country in one area of the world to another very, very quickly, it makes it a critical component to be able to share that information with the same standard across the globe. But some of the things that I didn't put on the slide here is setting up new healthcare policies, for example, monitoring resource utilization, because the level of detail that you have as a healthcare provider or a payer, you might be able to actually drill a little bit more deeper into the specifics of procedures that you will be performing within these healthcare clinics. Preventing and detecting fraud and abuse. We believe that those are some of the additional, again, intangible benefits of the ICD-10 that would come about. We talked very briefly about the 5010, and 5010, version 5010 to 4010 was the requirement to go from the 3 to 5 digit codes that ICD-9 had to the 3 to 7 alphanumeric digits that ICD-10 had. So think of it as widening of the highway. This was the electronic data interchange format to allow us to be able to submit ICD-10 codes. This had to go live early this year, so I'm sure everybody is already submitting in 5010 format. The reason I wanted to put this slide up is because some of the organizations, just like Rex is doing the same as well, some of the organizations are using an intermediary to transmit the ICD-9 or ICD-10 codes to the payers. So in other words, you could still to this day have your internal system submit in 4010 format, and as long as you have an intermediary that is taking that and converting into 5010 and submitting it, you might be okay for now. But as the ICD-10 rolls out, you need to be on the 5010 format so you can actually transmit these ICD-10 3 to 7 alphanumeric codes. So even though there may be a Band-Aid solution today for the 5010 submission, you still need to make sure that this is actually completely remediated within your organization. So what do the healthcare organizations do today? As we all know, the October of 2014 is now the new date. So CMS has pushed the date back by 1 year. But that may be a fallacy in the urgency of getting this program started. CMS has also urged that it will take about a couple years for the remediation, and I'll talk more about that and why it takes actually that much time in just a minute. But they have talked about the fact that if you haven't started it, start right away, because you will at least about a year or 2 years behind if you haven't started it. We actually, at Rex, we started in 2010, and we feel relatively comfortable that by the end of 2013, we'll be able to have had most of our systems remediated and our training plans in place, etc. But if we didn't start in 2010, we would not be ready in 2013. So that literally is about a 3-year period for us. And I would say, you could do it in 2 years, but you would have to really dedicate a lot of resources to it. Then there is this other issue about managing both the ICD-9 and ICD-10 codes. At least for now, we understand that there may be about a 1-year grace period that after October of 2014, we would have to be able to submit both ICD-9 and ICD-10 codes for a period of about a year. That's an added cost. And also keep in mind that early deployment could potentially reduce your costs. So at this point, for example, since we had planned on being live on October of 2013, we still plan to have most of our systems, if not all of them, remediated and be on the ICD-10 format by the end of 2013. This will allow us additional time to be able to test the systems and make sure that we're completely ready when the October of 2014. Over the next few slides, I'll talk a little bit about the way we set up the ICD-10 program structure within Rex Healthcare. We'll talk about the governance structure, talk a little bit about the dashboard reporting that we do, some of the budget and risk tracking that we do. We'll talk about our roadmap. But a couple of points here that I wanted to make before we move on to those is that we also elected to have a dedicated space and co-location of the teams. As you can imagine, you have your IT folks, you have your physicians, nurses, other healthcare professionals, your medical record coders, etc., that would have to come in and out of the projects to work on specific, whether it's training, whether it's workflow designs, whether it's system remediation. And so we decided to actually dedicate a space to be able to actually put folks there. That may or may not necessarily be feasible for our organization, but we certainly recommend that. We also made sure we have visibility across the entire organization, from an intranet site that is updated on a regular basis to newsletters and emails that go out to the staff to keep not only the key members of the team, but the entire hospital appraised of what's going on within that program. We did hold, by the way, several sessions, education sessions, within the hospital to educate everybody and bring them up to the same level playing field of what ICD-9 to ICD-10 is and what we plan to do and how we plan to remediate that. A few words about the recommended governance structure. This is exactly the governance structure that we have at REC. So, and again, this was modeled after some best practices out there. As I mentioned earlier, our CFO is the program sponsor. Chief Financial Officer is the program sponsor. Our Chief Information Officer is the program champion. So even though they co-lead this one, the CFO is the primary sponsor on this one. We have an executive steering committee that is made up of not only the CFO and the CIO, but also our Chief Medical Officer, our Chief Nursing Officer, our Chief Operating Officer. So at a very high level, this group meets about a month or every other month as needed, and they give us all of the support that we need to make sure that we're successful. Reporting to that executive steering team is the program lead, and I am the IT representative on the program lead. And Erin Moran-Gunter, who's the director of our Health Information Management, is the business lead on that. And then we have a program manager, Mr. Omba, who actually manages a whole host of consulting experts that we would bring in either from vendors that would be helping us remediate and upgrade the systems, to training experts, to medical records experts, to other types of consulting experts to come in and help us specifically make sure that we're ready. We have created a number of task forces from physician committees to financial planning committees, education and training, communication and marketing, and we create more and more task forces as we need them to tackle specific pieces. So for example, I'll use the training as an example. Our learning organizational effectiveness group here that uses learning management system, for example, has taken lead on putting all of our courses online for folks to be able to take classes on not only coming up to speed on ICD-9 to ICD-10, but also on any system changes that we might have or other types of impacts that we would have. And then we can also make sure that we track these courses through this team to ensure that folks are taking those classes and are prepared to go live with the ICD-10. This is not exactly our dashboard. That was just a picture of a dashboard that I threw up there just to demonstrate. But we decided to actually take our program tracking dashboard and divide it up into two different tracks, a business track and a technical track. And the business track, if you will, could include dashboard information such as physician documentation, coding crosswalks, and financial revenue cycles. On the technical tracks, we would track, for example, where our application upgrades are, our computer-assisted coding, end-to-end testing. Some of these other components that we track, such as training and reports, have both technical as well as business tracks. So we track those as well and report on those. I put up a picture of what we call our roadmap example. This is from back a couple months ago. This is exactly Rex's roadmap, or at least a portion of the Rex's roadmap. And as you can see, we track just about everything from chart reviews to workflow development to system remediations and implementation. You'll see right about the middle of fiscal year 14, fiscal year 15, we have a couple of red bars that are blocking just about 6 to 12 months of activity. That's sort of our, the first part of that is a slowdown, and the next part of that is probably some sort of a moratorium where we will not make a lot of changes to make sure we are ready for our ICD-10. And obviously, the duration of the time where we would maintain dual systems from there to about the middle of 2015 is where we would monitor our systems very, very tightly to make sure that we are in compliance. Again, this gets updated on a regular basis. We review this one with not only the executive steering team, but also the task force members and the rest of the hospital, and this gets updated on our intranet side on a regular basis as well. So as we were talking about the fact that there are specific codes for different encounters, there will be a code for walking into a lamppost, for example. I'm not even sure if we had it on ICD-9. We had an initial encounter, but I know for sure we did not have a subsequent encounter running into the same lamppost in the ICD-9 code. So again, a little bit of humor, but at the same time gives you an idea about the level of specificity that ICD-10 code would have. One of the last slides that I wanted to share with you today was the fact that ICD-10 codes, on the left-hand side, you'll see all the federally required regulatory timelines that are coming about. And again, this is from the American Hospital Association. So ICD-10 code is one of the key things that we talked about today. But on the heels of that, and at just about the same time, administrative simplification is another piece of requirement that, again, we don't have time to talk about that today, but there are some certain requirements for that one. I'm sure many of you have heard of meaningful use and leveraging electronic health record systems, and some of you may already be certified in meaningful use stage 1. And as you know, if you've been certified in meaningful use stage 1, it is not just a one-time effort that you get to that. It is a continuous effort that you not only get to the stage 1, and you have to maintain that. And once you maintain that, then you need to go into stage 2 and stage 3, which is continuous work that follows on the meaningful use certification of stage 1. Healthcare reform initiatives, and frankly, we don't know a lot about all of the impacts that it will have. Those are still being defined and refined probably, and that by itself would create new set of requirements as we go down into 2013 and 14. And then the HIPAA privacy changes that are also coming about. Again, this is the more reason why we want to make sure that folks that have not started on the ICD-10 remediation start today, because the onslaught of other regulatory requirements that are coming about are going to continue taking resources away from you. With that, I think I've covered quite a bit of slides, but I do want to urge that if there are questions, and we can go back and forth through some of these this information, please post your questions so we can address those. This slide deck will be available on DISYS' website, and my contact information is on here, and some of the references will also be available to that.
Great,
on that
thank
as well.
you, Peyman. I definitely want to open up the line to have questions through. If you can type them through chat, I got a couple here that I'm going to start with. I think that was some great information. It really gave a great overview, and it's helpful too that you included some of the things that you guys have done there at Rex, and you're obviously way ahead of the game. Since you got started so early and continue the effort. I know that we've seen throughout nationally that some organizations have kind of put off ICD-10 a little bit due to the changing of the date, and focus their resources on meaningful use. One of the questions I had, I think resources came up early on as a great concern for people. And where have you found, where your utilization of, contractors like us, like DISYS, in your organization, where are the areas that you think that you can augment your internal team to help support this effort effectively?
Yeah, great question. So there's a couple of areas that it hits the resource issue. One is training. So as you send folks out to get trained, you might need backfill for your existing work. So that may or may not necessarily hit the types of resources that DISYS provides, but it does provide requirement for healthcare professionals, nurses, doctors, practitioners to be but from say IT resources or other types of resources, because of the fact that we have a lot of our resources that are tackling day-to-day either projects or operational issues, we do need, and we have brought on board, extended number of resources for testing, system remediation, population, and all the other activities that are required for that. So even though some of your vendors may give you the base code to get your system up to speed, you still need to have folks that actually populate those databases and test those databases, making sure that they're, and I'm not talking about just testing, making sure that a code or two works. It's end-to-end testing of the system. So that those types of resources are normally not found in healthcare organizations.
Great, that's helpful. As you began this process, Peyman, when you went, when you guys started your initiative, how many systems did you think that ICD-10 would impact? And then what was the actual reality of the number of systems? Because that's one of the things I'm finding throughout the nation is that, in talking to folks like yourself, I think that they come up with a number of systems that they didn't anticipate having to remediate and test. So can you share a little bit about that discovery for you guys?
Sure. I think that was actually probably one of our most biggest eye-openers. So when we started looking at the assessment, and this is probably one of the reasons you want to start your assessment as soon as possible, we frankly didn't even know how many systems we had across the hospital. And we kind of anticipated that we would probably have over 100 different applications or systems. But lo and behold, we found out that we had over 270 applications and systems in the hospital. So after having sort of a heart attack, looking at the number of systems that could be remediated, we dug into it a little bit more and found out that probably somewhere around 50 of those systems needed quite a bit of work to be remediated, and then about another 30 or so that were tangentially impacted by the ICD-10. So I would say all in all, probably about 80 systems that are impacted and about 40 to 50 systems that are going to be majorly impacted and an overhaul of the code. Now, we were lucky. We were one of those hospitals that always had a policy for not building our own systems and always buying systems from the market. Some hospitals, and we're working with some of them today, that have decided and elected to develop some of their own systems, obviously have to remediate their own codes and their own internal programs, and that would be much more challenging than just getting an upgrade from the vendor.
How has that process been working with the vendors to get upgrades for RECs? Has it been challenging? Is it a project in itself managing that initiative?
It absolutely is. And vendors, as you can imagine, are at different stages. Some vendors are much more ready to have the ICD-10 code remediated and ready for us to go forward and upgrade. And some of them have not been preparing appropriately for this one. But that by itself actually requires quite a bit of interaction with the vendor. For example, not only tracking where the vendor is with the ICD-10 code upgrade, but also to what level and what are their expectations. As we get ready, for example, to work on some of our upgrades, we now are beginning to understand that they have certain prerequisites that we need to go do before they can actually do those upgrades. So all of those play into that, and that by itself is quite a bit of quite a project by itself. So each vendor of the 40 to 50 vendors that I talked about has its own project plan for remediation, and that's why we call it a program, because we're roughly managing somewhere between 50 to 80 projects between system remediation, training, and other types of workflow designs, etc.
Wow, that's a lot of projects. As you got started in this effort, did you find your network infrastructure or your databases also needed to be upgraded to help with this initiative?
Not so much. I think not so much, and I think that was partly because of the fact that we had a relatively robust network infrastructure. As I mentioned during one of the slides, we do use a number of intermediaries to transmit our information to the payers, to the insurance companies. So we had to make sure that our network infrastructure was relatively robust to even transmit all of our ICD-9, because we rely on those networks to be available and robust. Databases is a different story. For example, we have a product, and I'm sure a lot of the hospitals probably use the same one, called eGate, which is an interface engine between our various different systems, from billing system to registration to clinical system to lab systems, etc. Obviously, as you can imagine, this added ICD-9 to ICD-10 code we would have to go back and make sure that our eGate interfaces are able to manage and handle those exchange of information. That is by itself another major project.
Great. I have a question here from one of the attendees. For surgical procedures, their organization is assuming that they'll be able to schedule and document procedures as they did in ICD-9. And is that correct?
That's a good question. Again, I would have to specifically, you would have to specifically look at those scheduling systems. That should not make that much of a difference. However, the kind of information that you collect would be different because your medical record staff members go back to the example that we used, that there would be a code for getting injured in a chicken coop. And so depending on what the requirements are from an ICD-10 perspective, there are certain types of information we were not collecting to begin with that we would have to collect under ICD-10.
Okay. This is for behavioral health. So do you know what the status is of a crosswalk between ICD-10 and DSMV?
Great question. I do not know the answer to that one. And I will write it down, and I will find out that answer.
Okay, great. All right. We have maintenance agreements with our application vendors, and they keep the codes current. Why do we have to dedicate any cycles to ICD-10?
Yeah, good question. That came up on a number of times here at Rex as well when we started. So one of our major vendors is Cerner for our clinical systems, acute care side of the house. And obviously Cerner is a dedicated vendor. They will have code upgrades for us. They have put a very detailed project plan in front of us, letting us know when their system will be available for upgrade, what kind of prerequisites we need to go do, and when we can upgrade that. So we will need some base level resources to make sure that we manage and maintain and test things as Cerner upgrades our code based on our existing maintenance. That doesn't cost us any money to get that. However, once the system is in place, we will need to populate it with ICD-9, ICD-10 codes, crosswalk tables, and we need to test it, and we need to make sure that these are all appropriately running. And we also need to make sure that that system, the Cerner system, is interfacing with a whole host of other systems that are feeding into it and feeding out of the Cerner. So all of that would require additional resources. And as I mentioned, there are a number of prerequisites that we would have to get done before we actually go to the Cerner upgrade. So again, that's a very simple question, or an easy one for us because Cerner is on top of ICD-10, but even that would require quite a bit of work to be done before and after.
Okay, great. The next question I have is, what are the estimated costs or cost components for the ICD-10 conversion?
So, the cost itself is all depends on the size of the organization, the number of application remediation, and all of that. So it could vary quite a bit. But I can assure you that for an average size hospital, it is probably going to be in the millions. And that's why the experts in the field have all agreed that it is both expensive and traumatic. The cost components, and I'll maybe talk about some of the things that surprised us the most. So one of the major cost components, we knew it was the application remediation. We knew it was the testing and population of the information. What we didn't count on were two things. One was the training cost. And literally the training cost is now coming up to be just about half of the budget that we're putting in. And the reason for that is, for example, here at Rex Healthcare, we have about 5,000 employees. Of the 5,000 employees, probably about 200 to 400 of them would have to be extensively trained, which would require them to get certifications and go off to classes for weeks. And when they do that, we would have to backfill those employees so that we can continue our operation. Then about another 1,000 to 1,500 employees would have to have base level training which would require them to be away for about 3 to 4 days. Again, that's quite a bit of cost, both sending these folks to the training classes as well as the backfill. And then the rest of the maybe another 1,000 or so have to have base level training. Again, that's some cost. So that's one of the major costs that is associated with it. The other one that we didn't account for was workflow and workflow design. I guess we had accounted for that one. We just didn't know how extensive it will be. We thought that within about 3 to 4 months, we would have most of our existing workflows documented, and about another month or two to actually design the new workflows. We've been at about month 6 to 8 right now. I think we've been at it for a little bit over half a year, and we still don't have all of our existing workflows documented, let alone remediating and then coming up with a to-be model for our workflow. So that's another component. So add those two top cost components to your system remediation, testing for your applications, etc., and that's why you get that cost in the millions. All of those put aside does not talk about the cost after you go live with ICD-10, which are the hit on the number of FTEs that you would require for medical records and the number of accounts receivable days that would go up, and those types of tangential costs that come about after the ICD-10 go live.
Wow, that is expensive and dramatic. Thinking through that a little bit, it makes me wonder about those people that you're certifying in ICD-10. I'm assuming the physician population is going to have some extensive training. Do you plan for that when you have? I mean, I know some of your physicians are employed and others are not. I mean, is that part of your governance structure that you assume that they are going to understand the documentation required to be a part of your healthcare system? Can you speak to that a little bit?
Yeah, absolutely. So we have a number of physicians that are what we call the hospitalists that are part of the hospital. So they will get extensive training on this one because they for sure need to make sure that they can code appropriately and collect information appropriately. And so they'll go through extensive training. And again, as they go through extensive training, there will be requirements for backfill, and we still are in the process of determining how that impacts our hospital. Besides that training itself, we're looking at tools such as computer-assisted coding or other types of tools that will help our physicians and our clinicians to be able to not only get trained, but also be able to leverage some of the tools that we can give them. Again, we're looking at technologies like the iPads and iPhones and those types of things, as well as applications that can run on PCs. Then there are a whole host of other physicians that we work with. Either they work within our hospitals or on ancillary departments or our satellite locations that would also require training and education. And we're looking at both collaborating with these physicians that are not necessarily part of the hospital, but we're working very closely with them, as well as working closely with other entities, other hospitals and healthcare organizations in the region to make sure that these folks are appropriately trained and educated in ICD-10. So it's a very, very complex set of projects, and we actually have a dedicated team to the training and education.
Great. We're getting close to the end here. One other question that I have here is, given the election and given the fact that CMS has already pushed the date once, do you think, I know that the AMA is, has been vocal about it, but do you think that it's likely that this date will get pushed back again?
We've been contemplating that for some time here as well, and I don't think that would happen again, even though some of us probably were saying that with the October 1, 2013 to begin with. I don't think this will be pushed back anymore. Part of the reason for that is the fact, as I mentioned, is ICD-11 is coming right on the heels of this one. as well as there's a whole host of other requirements that the federal government has, including the meaningful use, administrative simplification, and other HIPAA requirements that are coming about. And frankly, a lot of those depend on the ICD-10 code remediation. So we pretty much think that the October of 2014 is it. This has been vetted out, by the way, this new date has been vetted out with American Hospital Association, with the insurance companies, with other providers and payers. So I think that the CMS has done quite a bit of work and they took their time. They literally took about a year to come up with this revised date. So I think there's quite a bit of thought that has gone into it, and it wasn't a trivial decision. But I think this is going to be the date, and I don't see it moving.
Okay. Well, I want to thank you very much for your time today and for sharing some of the scenarios that you guys have encountered there at Rex. I think that it's just helpful to hear from someone who's been through it, and if anything, to at least commiserate on the expensive and traumatic project that you're under, or program that you're undergoing. We at DISYS would love to hear from our attendees, and we'd love a chance to help you. Our goal is to bring more of this programming to you throughout the rest of the year and into 2013. So we'd love to hear any healthcare topics that you'd be interested in us speaking on or getting an expert to talk about. And we'd love the chance to help you with your ICD-10 plan. So both Peyman and myself, our contact information is there readily for you on the slide, and you can go to our website to learn more about us. We work with payers and providers and in software implementations, testing, and project plans. So thank you very much for attending today. Thank you, Peyman. I think you did a great job, and you can also see some of our other webinars out there that you may want to listen to. All the recordings should be out within about 24 hours after this call. There will be a recording that will be sent to you, and you can see the other recordings that we've done for previous webinars.
Thank you very much. Thanks for letting us share our experience with you as well.
Great. All right. Thank you. Have a great rest of the week.